Let me introduce you to my guest for this morning. And this morning, we are very, very happy, excited to have in the studio from my left, Dr. Lawrence Ofori-Boadu. He's an emergency medicine specialist, expert in case management and infection prevention and control in public health emergencies, a deputy director in charge of clinical development department of the Ghana Health Service. Just by him is Dr. Titus Bayo, Deputy General Secretary and member of the Infectious Diseases Committee of the Ghana Medical Association. He's in active medical practice at the Kolebu Teaching Hospital. Also here, from my extreme right, is Dr. Franklin Esiedu Bequin. He is Deputy Director, Public Health and Head of Disease Surveillance, Ghana Health Service. And just by me, on my right, is Dr. Abna Asumaning Entry, health economist and human rights advocate, specializes in policy analysis and health care access. She's executive director of Angel Zoe Foundation. She's also the author of 2 books. Ladies and gentlemen, good morning and welcome to NewsFile.
Thank you.
Good morning. Thank you very much. Now, before we start, we should actually start from JoyNews' Fred Smith. Fred Smith is an editor here at JoyNews, and he has some news for us. He's the head of the health desk here at Joy. And so, Fred Smith, good morning and thank you for joining us. Where exactly are you this moment?
I'm at the Labadi Beach Hotel in Accra.
Okay. What's your mission there and what can you inform us what's going on?
Well, my mission here is not related to the information I'm going to give to you at all. But the information I have for you is that Ghana could be announcing its 3rd case of coronavirus today. A gentleman who flew in, works at the Obuasi mines, we understand, was tested at the facility in Kumasi, and we do understand that this test turned positive, and we expect officials to announce that today.
Do we have any idea when exactly this 3rd announcement will be made?
Well, our information is not specific. It may be 2 days or 3 days ago. He arrived at the Kotoka International Airport. I do not know which airline brought him, but we understand he went by helicopter from Kotoka directly to Obuasi.
So we have an idea where exactly this gentleman is now?
Yes, he's in Obuasi as we speak.
Okay. Fred, thank you very much, and we'll be looking out for that. And so the expectation is that probably in the course of today or very soon, this morning, we are likely to have an announcement of a third person who has contacted COVID-19 right here in Ghana. Now, let me come to the studio and engage my guest. So, beginning with Dr. Boadu, what should we make of the circumstances as we are beginning to see come into Ghana? People are very frightened. Over 1,401 cases so far. 141,000, cases so far, 5,399 deaths recorded so far. But that other aspect which I suggested may be good news is the fact that 71,000 people have recovered.
All right, thank you very much, Samson, for the opportunity for us to be here to speak on your program. That is very wide and I have a lot of listeners, so we are grateful to be here this morning. For my take, I am happy that now we are beginning to identify people who are tested positive. Because when this fear of coronavirus first came to be, Ghana have been very proactive testing, and many of our listeners are doubting whether what we are testing are really what ought to be tested. Because as of now, Ghana, I know we have tested close to about 50, and if we are now having the third case, I'm just quoting from what you just said now, then it means that indeed our surveillance system have been very proactive, and our men have been on the ground working to pick, because that was our concern. How do we pick the first case, the index case that comes to country? How best can we isolate the person so that we minimize transmission to other people who might not be aware of the person's state of health? So to me, even though there's panic and many people think that we were praying that you shouldn't have to come to Ghana, to me as a clinician, I'm happy that at least we've been able to identify the few persons for now who happen to show signs and symptoms, and our surveillance system picked them and we have tested them. For us as clinicians, we are now going to keep them on hold, keep them on surveillance, watching, making sure that we manage them, give them the best care, and then we initiate contact tracing to see how many people they might have been exposed to these 3 persons. And I'm very sure the system has already been activated. So to me, it's a good news as a clinician. Now we have these people under our watch. Okay. And we continue to monitor them, continue to give them the best care. Okay. And I believe the public is also going to believe in our surveillance system now. That indeed what we are announcing as screening and having negative was indeed negative. Okay,
so we'll get into details, but Dr. Titus Bay, when you sit in your office and you get into your lab and you are attending to people in the wards and you hear this news, how do you take it and how do you tell people to take the news, particularly now that we are hearing that we are likely to have a third situation?
Thank you very much, and good morning to our listeners and viewers. From the point of view of clinicians and practitioners, those who are actually offering care to patients, it's disturbing news. I should put it that way. It would have been our wish that we never have cases, and that it's only suspicions, and we really never confirm the case. So each morning you step out into the ward or into the clinical areas, you are not sure which of your next patient is going to be a case, and then how you have to put yourself in order. But I think suffices to say that looking at all the preparations we've put in, the first thing is I tell myself to be calm. I speak to myself each day, and I speak to my colleagues that, look, panic and fear doesn't solve anything. It takes away rational thinking, and it helps us to behave in ways that worsen the situation. So what every clinician should be doing now is to calm down, go back to the basic infection prevention control measures that we know and the basic etiquettes that we're taught in medicine, and take local initiatives on your own, wherever you practice, and see how we can combat this thing. And I think that's the encouragement that we should be giving ourselves as practitioners, wherever you are, whether you are a nurse, a doctor, a midwife, at whatever level. What personal initiative or innovating can you do at that level to boost the confidence of yourself, the confidence of your colleagues, and ensure that it ties into our national plan so that collectively we can combat this.
We'll get to find out if the practitioners yourselves are not afraid, are not scared. We have the Nurses Association already issue a statement and suggest that if they do not have certain PPEs, then they would rather stay out of the isolation centers and not be involved. Now, Dr. Bequin, what do you know about what we are learning is likely to be the third case?
Thank you very much, and good morning to the panelists and then the viewers. Let me say that we have a protocol. So if you suspect a case, you send to a lab. It could be the Gucci or KCCR. So in this case, if it's Obuasi, that is likely it was KCCR. Normally, when the test is done and it's confirmed, it will be sent to the EOC, and then to be communicated to the DG and then to the minister, and then the minister will make an announcement. So as far as we are concerned, this is a rumor until clearly we've gone through the processes. But I think that, as has been said by Dr. Poebodu, I think that we are not very surprised because we are surrounded by threats. And if you look at the way, I mean, when the disease hit Europe, you realize that then the threat became very massive. So what is most important for us is, if you look at our drive, our intervention, ours was to early detect. If you early detect, then you can easily contain. Then in that case, you don't have spillovers that can overcome your system. So as far as we are concerned, it meets our direction about trying to address the threat of COVID-19.
Right. Now, I don't know what you think, Dr. Abna Entry. The World Health Organization says we have $15 million we're going to make available to countries that have weaker health systems. We have the World Bank announcing also that they are dedicating as much as 12 billion dollars. And here in Ghana, the president has announced that there is $1 million to assist in this situation. What does this tell you about the gravity of this prowling disease on the prowl?
Thank you, and thank you for having us for this discussion. For me, it's good news that the international world is not sitting and just observing, that there's a sense that we are all in this together. So that is a good feeling. But what that also means is that they are not just going to be picking the 12 billion and just distributing it easily. They're going to assess the strength of your systems, because some would go into capacity building, some would go into logistics, purchasing, and a whole lot. And it takes time. So my worry, whilst I'm relieved, I'm also worried a bit, because these monies, even though promised, do have processes that they follow before disbursements take place.
Now, Dr. Bodu, when the disease is declared a pandemic, from epidemic to pandemic, what does it mean we should be doing as a country? Are we doing that?
All right, thank you very much, Samson. Before it was even declared as pandemic, Ghana had already taken some steps, because we know now we are living in a global village where people move in and out of the country, travel to about 5 countries within a day and comes back. So our threat has been on our borders, because we didn't have it in our country. So we're focusing on how to strengthen the border surveillance, so that those who are coming in from the land or by sea or by the air will be able to pick them. So we took some steps whilst we're working towards how best we capture them. That along the line WHO announced as pandemic, we had to just focus on the steps we had already taken and then strengthen them. Now we have to call in more numbers. Initially, we were in a preparation phase where we were trying to put in measures, trying to get the desired staff and then retrain them, refresh them. But now we are looking at numbers, because now we need to open up to train volunteers, to train more health workers, medical students, get them on board. So in case we are getting overwhelmed, we will not be caught in the middle of the sea. So it's been announced as pandemics. Now we need to move as very fast as possible, get almost every health worker involved. We are not going to focus on a little few trained personnel, but now we need to widen our scope to involve every health worker on the ground, and even go beyond getting university students and nursing students, medical students already. So in case we have to get there, we will be able to respond appropriately.
So when you say you have been taking steps and you have sought to continue to focus on these steps, what steps are we talking about? And you are looking to increase numbers. What are the numbers we are looking at?
Yes, in fact, in responding to epidemic, we have an organization and a structure in the EOC. There's a coordination structure and there's a structure for case management, infection control. These are the structures we have been using to respond to outbreaks. So when we had this coronavirus, the same structures were activated. We call on members, we call on people on the regional level, on the various agency levels to be planning towards this outbreak. But when we realized that numbers are increasing, our neighbors are getting there now, we needed to widen up who are taking the port of entry, who are doing the surveillance, who are doing the case management, infection control, who are doing the coordination. Are the numbers available now enough to respond to this number. So these are the things, the various committee level, the various clinical staff who were voluntary. Initially, people voluntarily came out that we want to be part of the team we are training to manage treatment centers. But now we are thinking beyond managing treatment centers alone. We are thinking of managing facilities in Ghana. So in our planning now, once we are monitoring the numbers and the numbers begin to increase, then we are moving from just dedicated centers for treatment into facility-based treatment. And that's where we are thinking we need to get the numbers in preparedness before we get to the level.
So when I was asking about these steps that you talk about, I was seeking for greater detail about them. We are told that South Korea's approach seems less dramatic and more usable by other countries compared with that used in mainland China. I'm talking about where you have, lockdowns, is it?
Yes, sir.
Okay. And where, contrary to lockdowns, they are actually sharing a lot of information and bringing the public, directly into what they are doing. And that is helpful. Okay. What can you share? What are we talking about as regards the steps that you referred to?
Yeah, okay. Thank you very much for getting me back to the point. The steps involved apparently doing an outbreak response is getting our coordination system very strengthened, because they coordinate into the risk communication and social mobilization aspect when the community needs to be informed, and then we get them behind you. One thing about outbreak response is that if the community loses trust in you, whatever instructions and messages that go out, they wouldn't even read the messages any longer. And then one of the threats that we identified at our end is that people have already flooded the system with rumors. So one of the pillars that need to work at very fast rates to flash off the rumors is the risk communication pillar. That's a whole pillar that have experts in communicating who are working very closely with the Ministry of Information. So I think that is one of the pillars that we really need to get down to the community to now get information right, and then also having trust in what we are releasing from the ministry level. Because otherwise people are beginning to read anything that comes on the media, people are beginning to grab them. So that focus, that pillar, I believe is one of the areas we need to strengthen now. When the community is relaxed, when the community get the right information, when the community now believes that any information coming from the Ministry of Information, Ghana, is the only information, they will begin to rally behind us. So it makes the work of the clinicians very easy to integrate into the community for their support. That is one of the pillars I believe at this time we need to work. I know they have started, but we need to strengthen them. We need to empower them to move very fast. Once the information gets on and the community gets behind us, we'll be able to overcome the challenges ahead of us.
Dr. Bekwing, we are told that we are in a seemingly unstoppable spread of COVID-19. So if you have steps that you are rolling out, including isolation centers and whatever has to be done, can you bring the people closer to it by way of the information to Ghanaians about what exactly is being done, where are the isolation centers, what should one do when they have, any feeling that something is going wrong?
Thank you very much. I think that in trying to address this threat of COVID-19, we had several approaches. I think we kept on saying that it is not only at the borders that you will get a case, because you can only get the case at the border if it's showing signs and symptoms. But if you have a disease that has an incubation period of about 14 days, it's likely people will slip in. So before we confirmed these two cases, we had tested over 50-something. And it was only just about 6 of them that were seen at the borders. So our focus was at the health facility. And let me say that Ghana used a very loose case definition. The loose case definition was a bit more specific. Ours was very sensitive because we were not using quarantine. So it's like you can get a lot of people who appear to be having COVID-19 but may not be. So the idea is that you are not likely to miss. So we realized that we had about 56, and of those 56, about 33% of them were actually due to flu A or B. So it was not COVID, but it was looking like COVID. So that was our approach. And then if you look at our initial direction, or like our plan, it was not more of infrastructure based. But now, if you look at the numbers globally, it tells you that you need to now put in more logistics than originally planned. So that's how you can see that there's a big jump in terms of our budget to now what the president is talking about. Initially, you realize that there was very little focus on quarantine. Now, if you look at our drive, now we are trying to get quarantine facilities. There's even the direction of making sure that the existing treatment centers are now being re-equipped. So, original message was, you heard Tema and Rich, and then we talked about the regions, making sure that they have treatment centers in place. So we had a meeting last week, and then all the regions have treatment centers. I won't say they are fully equipped, but then you can demonstrate that they have a presence of a treatment center. Like if you talk about Takrady.
So let's get more specific.
Yes.
Initially, you were looking to deal with a capacity of 100.
Yeah.
That's what we were told.
Yeah.
And you were even looking, in terms of funding, you were looking for about 35 million Ghana cedis. Yeah. And you got how much of that?
No, because that
you
one.
Got 2 million of that.
That money was the quantum. So it was like that initial 2.5 or 2.8. It was 2.8. Was what you need to do immediately.
Right.
So it is not that they are giving you 2.5 of the 35 billion.
So now, from a capacity of 100, what are you looking at?
Now, if you look at the trend of cases being reported, you may get more than the 100. It's not very clear. But let me be clear, because we are focusing on early detection, it's likely we will not get such numbers. Because if you early detect, then you get very little contact, and then situation can be contained. That is how our approach is. And so all along, we never said that we don't expect to get a case in Ghana, because you cannot prevent a case from entering your country. Our focus is early detect and contain, and that's what we have been pushing. So if you look at the 2 cases that we confirmed, it took about 2 days before confirmation. So they got ill, 2 days, they go to health facility. Within a matter of a day, the results comes in. So somehow it fits into early detection. Unlike maybe you hear the case is ill, it goes to Konfanoche, it goes to Obuasi, then like 2 weeks, it's spreading across. So I think that we are on course to attain our strategy to early contain cases in the country.
Whilst you still may be optimistic that you may not get beyond the number that you had anticipated, in the very first 2 cases, if you are doing the tracing, I want to know, where are you expected to do the quarantine of the people that you trace at the designated place of quarantine, or where will you do that? Otherwise, we understand that one of them, for example, upon arrival in the country, had held a party, met with so many people. So for only one person, the tracing could get to as many as 100 people.
Yes, so I think that is not unexpected, because as I said, so if you look at the global pictures, you are looking at over 100,000 cases, and then you see only few of them actually get ill. So the idea is that how many people are sure that they could be ill. That's why if you have a very good contact management system, you can early follow your cases and then pick them early. When the cases go to facilities early, you are likely to get good outcomes. So if you look at the trend in cases, the late detection of cases lead to bad outcomes. So our direction is you follow the cases early, and then you are likely to report to the hospital early, and they get good outcomes. For a disease that spreads by droplets, you are likely to get them. So I think that the focus is you early detect them and you manage them, and then you don't get the poor outcomes that we anticipate. These
first 2 cases, you are tracing and hoping to quarantine the people you trace. Is that the case?
Yes, we are doing what we call contact tracing. So the idea is, you see, when it comes to a case and the contacts, the first thing is being able to identify all the contacts. So we are, as far as possible, trying to get all the contacts, and then we are going to follow them through the 14 days. So based on the situation, and it's case by case basis, there are cases that you can easily look at the circumstances. You can say, okay, these people are fine. There are instances that we say, no, you need to actually put on a different kind of terrain. For now, we haven't seen any odd persons as of now. So as far as we are concerned, we are actually following the cases. And one of the things that we started is we cannot be sure that we have gotten all the contacts, because we keep on probing and probing.
Those you get,
yes,
you quarantine them at your setup, your unit? Is that what you do?
No, for now, you are keeping them where they are. Because unless you think that circumstances is not good for them. But what you are saying is that
you keep them in their homes?
Yes, for now.
Okay.
What I'm saying is that...
What instructions are they supposed to follow while they are quarantined in their homes?
Yes. So the issue is, as they are in their homes, you try to make sure that they minimize their contacts with others. And one of the things that I have to keep on stressing is, we need to get the numbers right about the contacts. So that's the first stage of contact tracing, is the contact identification, and then you list them. So as much as possible, we are trying... So you go to one same person and ask you, is it possible that the past 2 days you have missed somebody? Let me be clear, if somebody has a girlfriend and is married, it's likely that person will not disclose as a contact. So you try to build rapport with the person that you will get more information than originally you get. And that's what we have been trying to do over the period, to make sure that we speak to them every other day, we speak to them to be sure that we have the first stage right. The monitoring stage is a bit different. And I think that we want to make sure that we get the first stage right, that we say that if something is infected, I must say infected, we are sure that you have 30 contacts.
Okay.
And then we can be following. Otherwise, when you have 30 and we start following 20, by the end, that 10 would have gotten us into trouble. So that's what we are focusing for now, making sure we have the contact numbers right.
Right. You were mentioning, is it Takrady or somewhere you wanted to use to explain something? What
I'm saying is that if you look at the 10, or let's say Ghana, we have 16 regions now. Each region has an earmarked treatment center. It's not wholly right. That's why the government's support is trying to put them up to an appreciable level that you can see if you can manage cases there. So like Kumasi South Hospital is the treatment center. Takrady or Western region, we've identified if you identified the Takrady Hospital. Then if you look at, I think Upper West, they have identified, I think, Tumu Government Hospital, and then the regional hospital. If you go to Eastern region, I think that's the regional hospital. So every region has an identified treatment center. And the idea is to build up their capacity, because we are actually looking beyond the minimal numbers to be sure that if we get cases beyond Accra, they can be managed. So that's the drive for a country now.
Right. Doc, what do you say about our preparation so far? The president has announced, has gone to see for himself, the places that we're preparing, and also he's issued a travel ban on ministers. We just heard yesterday the First Lady decided to cancel, an international women's, gathering that was supposed to happen in one of the hotels. And the Ghana Education Service has also issued a statement saying avoid, public gatherings. If you have speech and prize giving days, all of that halted for now. Make sure there is a lot of, sanitizers in the schools. But we know what is happening elsewhere. The schools are actually shutting down for a certain period. Right here in Ghana, some of those schools, as we understand, have shut down for at least some 3 weeks or so.
I'm worried a bit, to be honest, because our health system before coronavirus had its own challenges. We had so many deficits that we didn't need to add a coronavirus situation to. And so as positive as the $100 million sounds, which would take time to come into the system or get disbursed and be utilized for either logistics and all other things, I still feel that if we are running a system where we depend so much on the decentralization process, where primary health care, which a lot resides in the rural areas where majority of our population also live, what does that say to us? All that I'm hearing from our clinicians and policy implementers now is a bit high level for me. I would want to hear more of this is what we've done at the grassroots, because what does this kind of situation mean to a poor farmer whose grandson may have passed through, he came from Italy or someplace, so such scenarios. And how are we going to test our systems when, for instance, the CHIPS compounds are very, very ill-equipped? And that's supposed to be the first point of call for people at the bottom.
Right.
And we are sort of running a pyramid system here, where the urban population is at the top. This information we get through our system, our phones and everything, that's for people who can afford this level of phones. So technology is being used, yes, but how effectively are we getting that? So our preparedness, I still feel that it's a bit like how the Bible talks about when you're building a house and the foundation is not right. Even if you add on to it, the foundation may, cave in, exactly. So I want to hear a bit more. First of all, I was very impressed with the Ministry of Education and the Ghana Health Services collaboration. I would want to hear Ministry of Education's collaboration with local government, because we still run a decentralized system. We need everybody, as Doc earlier said, we need everybody on board. What does this mean for MESTI, Ministry of Environment, Science and Technology? We already are battling with challenges with sanitation, for instance. Due to the huge informal sector, we have a problem with even the informal sector enrolling on the National Health Insurance Scheme. And I would want to paint a certain picture for us to understand where I'm coming from in testing our system. If you were to go to Korle Bu, your first point of call, I work at Abu Blushi, and I feel funny, or I have all these symptoms that I feel I should report. I do not have National Health Insurance, but my first point of call, because perhaps it's close to where I live, is Korle Bu. Korle Bu is not going to tell you immediately, because it might have been something, a symptom that triggered my willingness to go to the hospital. So I go in there, the first question would be, and the processes would be, when you enter most of the facilities, you need to make payments, get a file, all those protocols are there. For the ordinary person, this is a bit intimidating, because first of all, affordability is an issue. You understand? So I'm just thinking that would this kind of impediments we have in the system drive people away who may be potential cases that, if the system allowed, should be in our fold? We should have found out about them, taking information about them, perhaps tested or not, to give us some outcomes, So these are some of the few nudging problems that I feel, we should be talking a lot more about, because the bigger population is not just at the high level.
Do you feel that managers of our health systems are being transparent enough compared to what you have followed elsewhere? They are telling us exact identities. I know there are rules about these of the persons who are infected.
I think for now, perhaps, and I'm going to be careful about this, perhaps for good judgment, this is a very sensitive situation where you could easily push people into a panic situation, where we are going to have a chaotic situation on our hands. So perhaps those who are managing information in this space are being careful not to let people get alarmed. But as much as possible, people want to know, for instance, the 50 or so cases that were tested, where did they really come from? How were they gathered? We would want to understand. We don't want identities, but the methodology that was used. And afterwards, okay, if within this space that they were tested and they were cleared, or you are still monitoring, if you are monitoring, which areas are they monitoring? Are these people, what are their profiles? Are they
can you speak briefly about that?
Exactly.
Did they self-report at the hospital, or you had to go looking out for them by some sampling method? What happened?
Yeah, so let me say that we actually spoke to the cases. There were two main approaches. So we have what we call the contact tracing forms, and that form gives an idea of who is likely to be a contact. So the person who is a case will now say, okay, based on this, then this person is likely to be a contact. So if, like the lady on my left, yes, because he's within a meter apart from me, and we have been here for the past 30 minutes. It's like maybe I sneeze or cough, then she's likely she can get infected. In that case, she fits into a contact. Or somebody that you have gotten personal contact with will be shaken. So we gave the forms to these cases, and they try to provide us the list. So what we try to do is that we, as I said, we are trying to get. So
this mainly came from the airports?
No. The
reason I ask is that I traveled just a couple of weeks ago, and I had to fill the form, particularly when we got back, and the questions were asked where I had been, if I had any temperature issues, you know, and so on and so forth. I wanted to know if the people did not self-report at the hospital for you to examine them and so on. How did you get to this? We want to have an idea.
Yes, so it's a little bit, there are two ways we do it. Like we started what they call the telephone follow-up. So we started it last week. We were to intensify it. So what we do is that we prioritize the countries based on risk. So like those come from China, South Korea, Japan, Iran, and Italy. And then we started calling them. So we call based on the information that they've put on their health declaration form.
Okay. And
the assumption is that that number is supposed to be right. And we have had a few problems. There are instances that the number does not go through, or it goes through and said the person has even left the country. So that one is to have an idea of what is happening to the case. That is one. That is not a contact tracing. It's more of like follow-up. The contact tracing is whereby you have a case and then you are trying to follow up the cases. And as I said, normally this is the case that provides you information about the contact.
Right.
Or you can decide to now look at the manifest and then look at the people who are likely to have been infected around the person. So there are several ways of identifying the contact, but the best person is the contact itself. Okay. But you can have other ways of identifying contacts.
So, Dr. Bayo, you have said that your attitude is to be calm. Yeah. And that is what you advise your friends within the profession and also the general public.
Yes.
Now, how can I be calm? Getting to know the statistics, and as Dr. Bequin said earlier, it multiplies within minutes. Okay, in just how many months? Over 141,000 people, and 5,000 plus are dead. Okay. How do I do that? Particularly get calm if I don't have sufficient information, if you are not being transparent enough.
Thank you very much, Samson. I think transparent, efficient, timely information is needed, and it's critical, and it's something we all must agree to. It's needed, and we have information going to two sets of people, and we always have to think about that. There's information going to the general public, there's information going to the frontline health workers. And I think the managers of our healthcare system must be conscious of this. You see, and the information must inspire confidence in the healthcare worker and calm down the general public. And so when information is not forthcoming, it puts a lot of questions in our mind. I am a clinician. When I heard about these two cases, first thing I was asking myself, okay, could there be more information? Could we know who these people are? Could we know by the next day how many contacts have been traced and what is happening? It inspires confidence in me that yes, oh, okay, the next patient I'm seeing, if the person is a contact, the person has already been listed, the person is being monitored, it gives us confidence that people are being followed up, but this bit of the information is not forthcoming. The announcement is made in the night, we hear about it early morning, you are hoping that by close of day, maybe another statement comes out that tells us that so far we have traced this number of contacts, and these are the people that we have followed through. That kind of information builds confidence in all of us, and also to the general public. They know that, okay, this person, this is the profile of the person, these are the people involved. If I'm just going to Abobuloshis, it's not likely that I'm going to meet somebody who is a contact, or 35 contacts have been asked to stay at home, they are self-isolating, somebody's actually calling them and making sure that they are obeying that, and that gives confidence to everybody. So I think the timely and efficient information that inspires confidence is critical. And if we are getting into higher numbers, it is something that we cannot wait for, even weekly briefs. It may have to be daily briefs. And that's why all sorts of digital communication means are available to give us that kind of information. But I want to also talk about other things that would cause us to be calm, and that is our level of preparation. While we commend the government for all that is being done, any preparation that is not in sync with our existing healthcare system will fade away, and we'll have to restart again when we get another outbreak.
What do you mean by that?
During Ebola time, we have structures erected. We had a few things put in place. After the Ebola outbreak, everything went away. And it's like when this thing started, we have to reactivate them and try to put things together.
What are these structures?
There was a center at Tema that was put up for Ebola. We had a place designated where the GMA called for the setup of an infectious disease centers. We said one in the northern half, one in the southern half. These were not done. Even the places that were identified and mapped out, they were not well resourced, and after the outbreak, there was no continuous resource to maintain these centers. So it's like we are restarting again. The other thing is, as we are speaking, we are asking managers of the healthcare facilities to take initiative. A lot of them are handicapped. And prior to this program, I spoke to people outside, we need to take initiative. And the first thing they all mention is, all our government facilities are running under debt from the National Health Insurance. Are we going to have this 100 million go to this facility to be able to take initiative? If we want a systemic solution to this, health insurance should pay facilities. And if it pays facilities at the chief center, at the district level, every facility manager can initiate some programs to keep their staff safe. They can create isolation centers. We are asking for isolation centers to be created. How do we do that when the people are under debt? They can identify the place they need to do some modification. The funds are not available. We cannot rely on central funding from this $100 million that have been promised to solve the problem. I think it is time we call on the health insurance to pay facilities so that managers can take initiative, so that we don't rely on the central source. If that is done, then people can take initiatives on their own, try to put up structures and help. Secondly, I think that currently the way we are going around this whole management thing from the national level is very good. It is giving information. The information should be more rapid. But I think as we delve down to the district level, to the regional level, we cannot rely on a few treatment centers. And as it is now, it looks like all our preparation is very helpful for mild cases, moderate cases. When we get to severe levels, where people need ventilators, I know the government is putting in place some measures to cater for that. How widespread is it? If you even procure the ventilators, these are things that you need specialists to manage. The ventilator, a ordinary nurse or another general doctor cannot put a patient on a ventilator. You need an intensivist. You need an anesthesiologist. These are the critical manpower we need. By this time, there should be some zoning out of the country, because most of the anesthesiologists we have in this country are located only in the teaching hospitals. So what happens in Wa? What happens in Bogatanga? So by this time, we should have a zoning out system that tells us that, okay, we have mapped out 5 anesthesiologists from Kolebu. This is the contract we have with them. We are sending ventilators to Upper West Regional Hospital. Should we have a case that gets to the level that needs respiratory support, these are the doctors taking care of that people. The same thing for Upper East. The same thing across the country, at least at the regional hospitals. Now, even if you are doing same, but you do not communicate it, again, it does not inspire confidence. That's what I'm talking about. So for the healthcare giver, for the practitioner who is working in Nandom, the person should be confident that if I have a case, the case is in respiratory distress, the patient can get care at the Upper West Regional Hospital, because even though they do not have an anesthesiologist now, we have 5 names of anesthesiologists who will be coming over to take care of this patient should the patient arrive there. If we have put these plans in place and we do not communicate same, confidence in the frontline workers will be low, because they don't know how their patients are going to be catered for. Even they themselves, if you are the doctor and you need the care, what's going to happen to you?
Dr. Bakwin spoke about self-quarantine and also quarantining people in their homes.
Yeah.
It's provoked something in me that we are told that this manifests within 14 days, right?
Yes.
That incubation period, do other people get affected?
The literature shows that yes, you can't have transmission.
So is that the best thing to do, keep people in their homes?
When you can't have infection whilst people may not be exhibiting signs. Commonly, a lot of the time, it's when they are exhibiting signs and they are bringing out droplets that the infection generally is transmissible. But there's been reported cases where people suspect that there can be transmission while people are not fully exhibiting signs. Now, self-quarantine at home can be very efficient if you have people who are disciplined, who obey the rules, and everybody, and they are being monitored. We do not want to create a state of fear and panic where you gather a whole lot of people to a place and then start testing and all of that. That brings a lot of fear and panic. So self-quarantining is a method that can be acceptable, but must be well monitored. You must have people who you know that each day you can call on them and be sure they are actually doing what they are doing. In some places, you may have to bring in force. You may have to bring in the security systems. You may have to bring in the police and military to make sure that people who are supposed to stay at home actually stay at home. Now, the person is confident to stay at home if he knows that the system can reach out to him. So if you ask me to stay at home 3 days, 4 days, I've not heard anything from anybody, and I don't know what is happening to me, the normal logical thing is that you may want to go out to another facility. You may want to get to the nearest hospital. So I don't think it's a bad method at all. It's a very good method. We can use it, but it should be well structured. People should be traced wherever they are. We should know. We should have regular
Dr.
calls.
Bakwing again was talking about the tracing where you may have some difficulty because somebody may not want to disclose the next person that they may have had contact with.
Yeah.
And you mentioned earlier also that you wish that the persons affected will be known.
Yes.
I don't know how that sits correctly with your rules of confidentiality, or that in emergency that doesn't work. And don't you think that if you got to know who was involved, maybe the general public could be of help?
Yes. So it plays in different ways. The first thing is that when we make the persons known, the people who were contacts can self-report.
Right.
And so that even if the person is not disclosing them in their contact list, they can self-report.
Okay.
But there are critical issues of confidentiality. And in the case where even diplomats are involved, then it becomes even more difficult because you must be careful of your diplomatic relationships. However, I think the first thing is to encourage the people. In medical terms, that is the easiest way to go around confidentiality. If the people self-report, we've had people issuing personal statements. We've had prime ministers, we've had members of parliament in other jurisdictions issuing statements that I have been infected, I have been exposed. So if we encourage the people to self-report, I think it's very beneficial. It's difficult for the health system to come out and say that you, Mr. X, you were the patient, because that would breach fundamental confidentiality rules, unless we've gone into a state of emergency where those rules can be waived. As of now, I'm not a public health specialist. I don't think we have reached that point where we can break that confidentiality between the patient and their clinician. But the persons involved should be encouraged to self-report so that they can issue personal statements. If they are people of high ranking, they can come out. Because in that case, this is not a disease that is associated with stigmatization, but it will help us to come out with a contact. Because people can then call the emergency lines and say, yes, I'm a contact, and I met this person, I was at that party, or I was at that event, I haven't been reached yet, what is happening? Then it can help us with our contact tracing. So I think, in fact, I will use this medium to appeal. And if the persons involved are listening, I think full disclosures would help us. That is where the transparency bit comes. It's difficult for the health system to do that.
Dr. Boydu, a professor at the University College of London, says that politicians are overrepresented in the number of people who have been diagnosed. And we know that elsewhere, we've gotten to know the names of persons who have been involved. Dr. Bayo is saying this is helpful. Why are we not able to get close to that?
All right, thank you very much. Before I answer that question, let me just make some few clarification, because I am also involved in the case management aspect, where we try to manage people depending on their level of exposure and also their severity of their condition. Okay. Tato spoke very well on the self-quarantine. That's one of the basic things we are encouraging in the country, that people who are contacts, people who have mild conditions, the person has been tested positive, but he has no signs. It's okay. Why should I pick the person and put in a small room somewhere and add more stress? So those who are contact and those who have almost, they call them asymptomatic, he's tested positive, but he has no signs, no symptoms.
The First Lady of Canada just returned from a speaking engagement in London and decided that she will test and made an announcement. Yeah. So she, together with her husband, are isolating.
Exactly. So that is one of the forms of management that WHO has recommended, and it's working well. Many people who are tested positive. One thing about testing is that in Ghana here, we are just trying to allow people to be tested, but we don't want to cause panic in the system, that everybody just wants to the place they want to be tested. Because the fear is that when people start jumping to be tested, they get a lot of panic attacks and start moving around. If you test and you are not positive today, doesn't mean you'll not be positive tomorrow. So that's why we are still limiting people for testing to our case definition, that you must meet the criteria A and B, where A means that you must be symptomatic. showing the signs and symptoms. And B must be that you must have that epi linkage. You must have contact with somebody. If you meet this criteria, we will narrow down to just minimize anxiety in the system.
That elsewhere people are rather encouraging that.
But when we get to the level when there is
tested,
no, we were at a certain
discover
level.
the slightest sign symptom.
We were at a certain level of preparedness when we didn't have any reported case now. Now that we have reported cases now, I know that the response will be modified.
Okay.
But it's not going to be taken away completely. Like people can just walk around anywhere, wearing face masks anywhere, because 1 or 2 persons have been tested positive here. So I think the general public education, as I said, is very good. Self-quarantine is a method of treatment that we also do. So we are moving on that. For personnel, I'm on the side of clinical management. So the personnel, as you rightly mentioned, we have a lot of people who are specialized in our system. As we started preparing for case management, we needed to document and find out where who is in our system. Because in those days, we were relying on teaching hospitals in our treatment, because that is designated for treatment of cases. Teaching hospitals is modified that they actually, the primary function of teaching hospitals is not to do the primary care, it's not to do the basic public health, but they are all curative, where they have the specialized people there. So we have a chunk of our specialized staff in teaching hospital. But then recently, a lot of public health education has gone on. Many general practitioners are into public health. So we have widened the scope now to involve almost everybody. So I believe that for now, we have done a lot of mapping. For this preparedness lesson we are doing for now, Kolebu is fully involved, Conference is fully involved. Our personnel who have developed our SOPs we are using currently, about half of them are from teaching hospitals. So we are doing well. I think that for case management, and now we have cases in the country, we are hoping that it doesn't get to the worst form. Because as of now, the 2 we have had, they are all mild cases.
Do you advise that people who are coming or returning from countries where COVID-19 has been, discovered or people have been affected, should self-isolate or go test? Do you advise that should be?
Yeah, that protocol is already there, and I want to reiterate that that's the best way. Because if you come from an affected country and you don't have any, you are not sick today, it doesn't mean that you'll not be sick within the next 14 days.
So we advise those who are calling, for example, that the president and his entourage after their return, should also get tested or at least self-isolate. They are right. For self-isolation, if you haven't gone beyond the specified incubation period, we advise that. But if you are gone beyond the 15th day, the 16th day, and you are still asymptomatic, we don't want to minimize your movement after the 16th day of being to a place. Okay. But if you haven't gone beyond the required 14 days, as we are using our case by definition now, we advise you to be self-quarantine, minimize social gatherings, and ensure that you observe the basic precaution measures of keeping yourself there. So I will say that's fine. For now, in emergency response, until you have the first case, you wouldn't know you are prepared. Yeah. And that's one message that Ghanaians, and I really appreciate the concerns of the public. We are still not sure we are prepared. But I can assure public that for our systems, we have very refined physicians and nurses who are well trained. What they need to get is to get the basic logistics, which have been already, they are not enough as a speak now. We need more. We need people to donate more. But then we have the basic that we have started. I believe that if the system is able to put itself together and we get the logistics support from other agencies who are around, everybody should come on board now. Okay. We need the numbers. I'm taking a break, but Dr. Abnechi, in a minute, listening to those at the front line of the management, are you getting the assurance that you didn't seem to have? And he also has concerns that the general public doesn't seem to have that assurance. Are you getting that assurance that we are ready?
First, before I respond to that, I would want to say that for lack of adequate information, people seek fake news. It's very important. That's what everybody, the authorities, should take with them. We all know coronavirus is here. And if we are not getting the kind of information to feed our anxieties, we are going to feed on any kind of information that comes. We have a lot of some faith-based organizations talking about spirituality and all that. We have people who are spiritual. They will go in for that. So that's on the information bit. The confidence part, I still feel, this is very good. I still feel that we need a lot more to give us that feeling that should there be more than 2 cases, we are ready, that we will not be running helter-skelter on the streets. The information so far is not too great for us. It's not enough. But the self-quarantine bit too, I'm worried. I'm worried in the sense that how many people can afford to self-quarantine? I'm a mother of 4. First of all, your children may not allow you to do that. Even if you are and you can afford it, the circumstances, social circumstances may not allow you to do that. What do? We need to give different scenarios as to if you're a mother, a single mother, you don't have help, this is where you can go. And I speak for women. This is a month for women's celebration. We need to make them change agents in this path. So the multi-sectorial approach that I want to feel, I want to see, that will give me the assurance. I still want to know what we are doing. It's not only cancelling social events. What does it mean for the single mother who still has to work to feed those children?
All right. So we take a break here, and when we return, Dr. Abnanchi, I'd like you to be specific to tell us some of the things you need to see to improve your assurance that the right things are being done, or that we are prepared. There are some who are raising questions about borders, airports. They seem to suggest that the seaport is neglected and so on. Dr. Bequim and co will assist us to understand all this. But more importantly, we shall be going through the ABC of how to stay safe. We'll be right back.
Has been assessing this outbreak around the clock, and we're deeply concerned both by the alarming levels of spread and severity and by the alarming levels of inaction. We have therefore made the assessment that COVID-19 can be characterized as a pandemic. Pandemic is not a word to use lightly or carelessly. It's a word that, if misused, can cause unreasonable fear or unjustified acceptance that the fight is over, leading to unnecessary suffering and death. Describing the situation as a pandemic does not change WHO's assessment of the threat posed by the virus. It doesn't change what WHO is doing, and it doesn't change what countries should do. We have never before seen a pandemic sparked by a coronavirus. This is the first pandemic caused by a coronavirus. And we have never before seen a pandemic that can be controlled at the same time. WHO has been in full response mode since we were notified of the first cases. And we have called every day for countries to take urgent and aggressive action. We have rang the alarm bell loud.
Thus far, our points of entry, such as our airports and land borders, continue to show satisfactory preparedness to screen all entrants into Ghana. The Ministry of Health has designated a quarantine facility that can hold infected persons, whilst regional hospitals are preparing isolation centers for holding suspected cases. Our country's two main research institutions, the Noguchi Memorial Institute and the Kumasi Center for Collaborative Research, which have the capacity to investigate and confirm or otherwise suspected cases of coronavirus infections, have been very supportive in this regard. So far, they have found that the 57 suspected cases, as of today, Wednesday, 11th March, have proved negative. However, it is imperative that we step up our preparedness to ensure that beyond these initial satisfactory measures, we adopt a whole-of-Ghana approach in adequately preparing for a possible hit within our borders. In order to do so, at my prompting, the Minister for Finance has made available the CD equivalent of 100 million United States dollars to enhance our coronavirus preparedness and response plan. That is to fund the expansion of infrastructure, purchase of materials and equipment, and public education.
The Minister of Health has confirmed 2 cases of COVID-19. The cases were confirmed on the 12th of March, that's today, 2020. And the first cases to be reported in Ghana. Laboratory results of the 2 confirmed cases were received at the same time from the Noguchi Memorial Institute for Medical Research. Both individuals returned to Ghana, one from Norway and the other from Turkey. So these are imported cases of COVID-19. Both patients are currently being kept in isolation and are stable. We have initiated processes for contact tracing. I wish to assure Ghanaians that the government of Ghana, together with all health partners, will continue to work assiduously to ensure the situation is contained. We wish to encourage every Ghanaian to take care of their health and that of their families by adhering to the following precautionary measures: regular and thorough washing of hands with soap under running water and use of alcohol-based hand sanitizers. Avoid shaking of hands. Keep a distance of at least 2 meters from a person with fever, cough, sneezing, and difficulty in breathing.
And the health minister continued by saying that it is also advisable to be physically active, drink plenty of water, eat healthy, avoid stress, and have enough sleep. Stay home if you feel unwell with symptoms of fever, cough, and difficulty in breathing, and call the following numbers immediately: 0509 497700 and 055 8439868. So let's get to Dr. Bequin again and find out when the president says we need a Ghana, whole Ghana approach. What have we done, particularly with a question like this from Rock in Ejumako? He says, is it not the health minister who came out with a press release that anyone who enters the country will be quarantined for a number of days to study the person? Has he, the health minister, and his team taken action on such directive? When did the 2 persons arrive in the country? How are we going to get all those they have come into contact with? So far, there's no any announcement about how many have been traced. What do you say to Rock in Ejumako?
Yes, thank you very much. I think I need to state that there are 2 approaches that are being used, because and I think I started talking about it earlier in my discourse. What we started is we want to see how early we can pick somebody who does not, this is self-quarantine or self-isolate. So as I said, we decided to pick the health declaration forms, and then we started teasing them out, and then we started making calls, and we've gotten some responses. One of the things that we want to come clear, we want to encourage the public that there's an essence in why we collect information, because if I take your number and it's not a good number, there's a challenge. Let me tell you, there are some instances that people that we make their calls us back, that we missed the call and want to confirm that I came from Italy, I'm fine. So it's a process that has been started, which we are going to scale up. But I think that, so if you get a call, don't be surprised, because we try to pilot it to be sure that that's one way. It's a very expensive procedure, because if you, like in a week, you're looking at about 500 people who fit our at-risk countries. You'll be getting calls. That's one approach. The cases that we had confirmed, these are people who somehow were not fully self-isolated. But for one in particular, he is not somebody who is very actively involved in everyday activity. And we are still trying to ascertain how he got the infection. But what we are trying to say is that for now as a country, if you look at the government's approach in terms of raising our budget, we are now going to have a very detailed approach to quarantine. You know, in an initial approach, there was very little focus on quarantine. Now we are looking at self-quarantine and even quarantine. So the government has earmarked quarantine facilities. And based on your assessment, you may be moved away from self-isolation or self-quarantine to actually a quarantine facility. And a quarantine facility has actually been acquired, about 2 or 3 of them, some even outside Accra. That if you look at your circumstances, we think that you cannot self-isolate, self-quarantine, you will put it there. So I think that in the next few days, you realize that will come out clear guideline that though in the time past, it was kind of fluid about quarantine, now people will be moved. And we want to say clearly to the general travelers outside that entering Ghana will not be that easy for people as it used to be, because you may be sent into a quarantine facility if you enter the country.
Interesting. Dr. Boadu, there's someone who is asking, Christian Ayenso, he says he's an evangelist, he's traveling across the world, and he wants to know that he should be able to self-test. He's been listening and watching, following Sam George, the Member of Parliament, Dr. Zenato Rawlings. All of them have suggested, Sam George particularly, that he's seeking to self-test. He's not getting any help.
All right, thank you very much.
And how much does it cost to do it?
Okay, thank you. I want the public to just note that as of now, we have systems and protocols we are working with. As a system, we need to follow laid down procedures so that we don't cause chaos in the system. For people who actually need to be tested, we will test them. We have a criteria for testing. The fact that you have traveled to a country that has the outbreak now doesn't mean that when you come, we have to pick you at the airport and go and test. The physiology of the body doesn't work like that. So we have a criteria we are following. If indeed you fit into the criteria, you will be tested. The cost now is free. We are not charging anybody for testing.
Okay.
Once a doctor fills the form that Mr. A has met a criteria of having signs and symptoms, and we have been able to establish very concrete epi-linkage that he has traveled and had contact, that Mr. A will be tested. The fact that you have gone and had contact alone and you are not showing signs and symptoms now, you don't meet that criteria for testing. That is
if you discover that at the border.
Yes, even if you walk to our facility,
yes,
a physician will take you through the same. It's a screening form that is being used based on our case definition. Any physician,
are you saying anybody who goes to the hospital is going to go through
If you go and say you are sick, he will ask you, where have you been? Now every physician will ask you, where have you been for the past 14 days?
Okay.
When you went, what did you do? That will be establishing the contact. They come and ask you, how are you feeling? Do you have headache? Do you have fever? Do you have sore throat? Running nose? You want to get the second part of the criteria. When the two, A and B, are met, automatically we will offer you that this is what we are feeling. You are meeting our criteria of a suspect. So we are going to test you.
Right.
And once we are testing you, the test is free.
All right.
And then we'll be able to lay down the results to when the need be that you are a suspect and we cannot allow you to go home at that moment, we keep you in isolation whilst we wait for the results.
That's very encouraging. And Dr. Bayo wanted to say something.
Yes, I just wanted to add that when people do panic testing and we test large populations, we call that surveillance testing. And data from China, where this thing started, have shown that it is not a very efficient approach. The yield is usually very low, and we waste resources, and we do not pick it up. And I want us to depoliticize this. It's one of the things the GMA is calling for. Let's take this as a national fight, and let's all support no politicization of it. The final bit is that when it comes to testing, I have heard the head of Noguchi make a clarion call, and I think we want to add our voice to that. They need to be resourced. I have personally been involved in the suspected case. I cannot give further details because of organizational rules. But to the extent that as it is now, in some instances, Noguchi cannot run tests at some point of times in the night. And so if you have a case at some time, they cannot run the test. It has to be run the following day. And they are saying that they need to resource a lot of kits. With what we have to use it efficiently. So if you are testing everybody, we would waste it. And so everybody should follow the laid-down protocols, and let's make sure that you meet the definition to be tested. However, we will appeal to government and to everybody that the resources that has been made available, one of the critical institutions that will help us in this fight is Noguchi. And Noguchi should be given the resource needed, because once we cannot make a confirmatory diagnosis, we are in a period of speculation. And if they are resourced in terms of the manpower as well, so that they can run 24/7, there shouldn't be a period within which samples cannot be sent there. Because if you are in the state of the caregiver, it's a lot of anxiety. If you are self-isolating, you have examined a patient meets the criteria, you need sample to be taken, or sample has been taken and sample cannot be run till the next morning. That night is a terrible night for you. You cannot sleep. You cannot do anything. So we should get to a point where this testing is 24/7, and all the resources needed should be made available to Noguchi.
Okay.
Can I chip in something
right.
small? I think it's not only Noguchi that is testing now.
Yeah, and then the
KCCI is also testing. So
they need all the resources.
We want to make it very clear.
Yeah.
Noguchi initially has the capacity to run 24 hours. What we are trying to do as clinicians is not to expose our people to be tasting samples mid in the night. Because the risk is, the protocol is that when the visibility is very poor, don't be in a haste to take specimen. Because overnight stay of a suspect will not cause the person to die, but you as a clinician can expose yourself. So in our protocol, even though Noguchi can run 24 hours, we are minimizing running to take specimen at night when it's raining. We are running in to get somebody tested. So we want the public to also understand that it's not just Noguchi who is saying we cannot test 24 hours. We are also trying to put measures to prevent exposure of health workers unnecessarily. So if you come and it's now 10 p.m., 9 p.m., and we can give you a place to stay overnight, we will advise you to hold on and we do the first morning. Unless we cannot keep you overnight, then we'll be able to do it. And in that case, when communicating to Noguchi, they will respond to the call.
What do you make of this approach that was taken by the UN office here in Accra? And they issued a statement, and among others said that one of the 2 cases of COVID-19 announced by the government is a UN staff member who worked in one of the UN buildings until the morning of the 12th of March 2020 to ensure the safety of all staff in that building and the continuation of our work for sustainable development. The United Nations in Ghana has decided as a precautionary measure that staff on those premises should work from home. This measure is taken temporarily, and decisions are taken in coordination with the national authorities. This supports containment of COVID-19 and is in line with the United Nations Worldwide Standard Business Continuity Procedure. Other staff working in other UN entities' premises continue working in the office normally. We are told that even schools that children or a child of one of these people attends have also taken the steps to say we are not opening. What do you make of that approach?
Right, thank you very much. In fact, asking contact to stay away from public gathering is the right step. So once you are confirmed as a positive case within a vicinity, everybody over there who work with you over that period is assumed contact.
Okay.
So the best way to do is that disperse the crowd.
Right.
Let them be in their isolated area so we can track them. The good thing is that some of this report, doctor can tell you, they have given us names and contact of their staffs. And then we are following them up. I am not in that department, but I'm aware of that information that contact has been given. When a contact is a student, a child who gets to school, definitely the best thing is to keep the child away. But the authority were not aware. The child has been in the school for the past 3 or 4 days already. So it's assumed that there has been some contact from the child, even though the child is not exhibiting symptoms.
Okay.
As Dr. Teto said, that it is believed that people get more infectious when it starts showing symptoms. But COVID-19 is quite tricky. You have had people who are asymptomatic, but they are shedding the virus. If you say they are shedding, the virus have been found in their feces, in their urine. But it's not very clear whether those who are symptomatic are still transmitting or not. Right. So we are still taking measures to be very careful.
All right, Dr.
So
what do you make of this kind of approach? And of course, we know the GS has come out to say no crowding. Tomorrow is Sunday. People will go to church.
Yes.
Yesterday was Friday. People went to the mosques.
Yes.
How about all of that? And plus, my question to you earlier, what specifics do you need to assure you further?
Yes. I think that's in the right step. I have a few friends whose children are in international schools, and yesterday they made preparations to say that our children are going to be home for the next week. So as mothers, as fathers, they understand the context. Some of these children or their classmates have parents who have gone to Turkey, they've come from China, you know, so the rate of transmission can be managed appropriately if this kind of closure happens. However, I don't think that we should be encouraging too much of it because we don't want to cause panic with two reported cases yet. So I'll be watching that space to find out what other schools will be doing. I know my children's school, for instance, they are not closing them yet, but my children tell me that at assembly, instead of, you know, stretch your hand to the next person, now they say, don't touch your friend. And as they are playing, don't hug, don't do, you know, so these basic things are being done. And so I think it's in the right direction. To the point of what I would want to see to get assurance in this journey, and I call it a journey because we all don't know the end state yet. The first is that one of the challenges known in our system, Ghana here, is the poor health professional attitude. We need the health professionals to have good attitude at this time because poor attitude serves as a barrier to access. If the person comes, they have a little headache, you show bad attitude, you don't have that, you know, they would end up going. And when the person turns away from the health facility and goes home, perhaps they go and infect maybe 100 or so people. The second I would want to see, and this is from everybody, especially in government, is I would want to see a very clear strategy which is multi-sectorial. As I mentioned earlier, where I said it's good to have GES and GHS working collaboratively, I would want to see what the Agric Ministry is doing with Ministry of Health, for instance, because we have extension officers who go to the rural areas. I would want to see what the local government is doing in terms of sanitation. Because like I said, we already had our problems in terms of health, and then now Corona has come to compound it. The next point is I would want to see intensified public education. This is very important to me. I feel the education that's going on now is very high level. I've written, I have a working paper on how people in specialized groups, for instance, are not able to access healthcare. And we are talking about people with disability, for instance. I'm talking about pregnant women who can't go to gatherings because maybe they are heavy. And so what strategies, specific strategies are being put in place to communicate with these specialized people? So if you can't hear, you can see. What communication is there? Because we've seen the audiovisuals from Ghana Health Service. What does it mean to the person who is an illiterate? I see the images out there, very good. Some people will still see these images, won't understand. There's one of the posters that talks about do not shake hands, but the image is that of somebody holding the person's hand. So I see it, I'm thinking, okay, are you saying I should be holding people's hands? Or you're trying to tell me not to hold hands? There's miscommunication in this space. We don't want that.
But you have done a translation of the messages.
Yes,
and you have them in different
languages. Yes, yes. And that's what I'm trying to say, that that is good. But we need to be, it should be intensified. And the consumption of these this information is very important. Right. You know, the other point is that the point of entry, and that's what people have been talking about. What is it? Because I think about 2 weeks ago, CCTV or something showed Aflao and how they were prepared for coronavirus. I was particularly not very encouraged when the immigration officer was telling us what they've been doing. And I've been to Aflao a number of times. The people just, I mean, Sister Comfort is over there, Auntie Rabba is just here. We are just sisters, you know, across the border. What are we doing? We want to see that they are coming in, but there are concrete steps to, you know, isolating people when need be and all that. My final point would be on the involvement of women. Women form a greater percentage of the population in Ghana right now. And women are a powerful source as change agents. So our fertility rate, I think we are at 3.9% per woman in terms of children. So let's just say we all even have 3 children. looking at the population of women in Ghana, we educate or we make our information or education, public education, sensitive to women who in the end would end up going home to educate their children, okay, because the children can bring it, but they don't survive, they don't die, you know. And women, because we are caregivers, if we have an elderly woman at home, we can take appropriate steps to protect our households. So I think that in all our communication and our strategies, we need to be able to identify these groups who are powerful, who can cause the change we want to see, and then we all win this coronavirus problem in a concerted manner.
Thank you very much. Now, Dr. Bakwing, this is a question from Guy G in Newark, New Jersey. He says, besides the $100 million provided by the government to enhance coronavirus preparedness, what are the steps to ensure the safety of healthcare workers as they deal with the ongoing outbreak of the disease? Okay. And I told you about the nurses. They issued a statement, and they said for as long as you find that the isolation center or unit, you are not properly equipped with, you know, PPEs, you should not take part. You should rather, you know.
Okay, thank you very much. Let me say that the government provided an initial set of PPEs. And those PPEs were actually distributed per region and then per teaching hospital. We made a limited supply to the quasi hospitals, quasi-governmental hospitals, and some private. We do not think that that is enough, but the government has assured to get additional 10,000. Just yesterday, World Bank has given us another 3,000. WHO has given us some quantity, because the idea is you want to prevent the health worker from getting infected. So it's an ongoing process. And as I said earlier, if you look at our initial budget and what the President has promised, there's a big quantum. So it means we focus clearly on provision of logistics. And I think that's the way you're going to make sure that the needed PPEs are going to provide it. We as, let's say, Ministry of Service, Ministry of Health, we see the first two cases as a simulation, because it's testing us where we are going right and what are the challenges. And clearly we are clear in our mind what we need to change to make sure that we get the best for the country. In terms of the port of entries, people can attest to that. I think Kotoka has seen an improvement, but there are other areas that have their own challenges that we are critically looking at. A team went there to Aflao last week. They've come clear with the gaps that exist. Likewise, when we met the regional directors last week, each regional director was tasked to ensure that the port of entry actually brought to the standard that is required. And hopefully the new amount of money from the government will help address the gaps that exist.
All right. Dr. Bayo, what should I look out for? What are the symptoms and what should I do? There's this question, may sound a bit funny, but it also is an important aspect to address. Bipwa Mohammed in Wa says, all China products don't last in Ghana. Same is this coronavirus. It will not last in our environment. Does the temperature of the environment play a major role in, you know, the spread of this disease?
Okay, so I think, thank you very much. That's a funny one, to say that all products don't last. It cannot be ascertained. However, this virus is a very novel one. It's one that is under study and is difficult. Its characteristics is not fully known. There are suspicions that it may not do very well in our environment. But once we've tested positive for two people, it is safe to assume that it is here with us, and it can be here with us, and then tackle it head on. So let's not assume that it cannot survive, because at least there's surviving two people here. So that's what I would say. Now, in terms of the signs and symptoms, I think these have been well publicized and we know about it. The fact that you may have a contact or the travel history, very close contact or travel history, and then you may have the respiratory symptoms of difficulty in breathing. And it is pretty much like, in the initial stage, like a common cold, like a common flu. So the contacts, or what he called the epi-linkage, is very important, that you have had a contact with somebody associated with these symptoms. If not, as the rain setting, we are going to get people getting common cold, and then they'll flood all our facilities because they have a cold. But that contact history is critical, and then associated with the fever. But I want to emphasize on one thing, which is because, as we mentioned earlier, people are feeding on information from different sources. We are using less effective means. And it is one thing the Medical Association wants to bring to the notice of everybody. We are seeing people in panic, wearing gloves in public spaces, working and selling food and wearing gloves, selling things and wearing gloves. Now, it is very counterproductive. It gives you a false sense of security. You are not likely to wash your hands often because you think you are protected with the gloves, and then you may actually be infecting yourself and infecting other people. The number one proven efficacious means is the hand washing. And we would ask everybody to practice that. Let's make sure that we have hand washing facilities. If you are a facility manager, a private institution, health or otherwise, make sure that you make it possible for your staff and visitors or people who use your place to wash their hands. And the use of the alcohol-based hand sanitizers is also very, very useful. Face masks is useful, but only to the extent that someone is showing symptoms. And this is more useful on people who are showing symptoms than to the general public wearing it around. So if you think that you've had a contact, you are coughing, use the face mask if you have it. It saves other people, then you don't distribute the droplets. But let's not all panic and then go wearing face masks around as we walk from day to day. Okay. It may be helpful if there is mass outbreak, but at this stage, I don't think that is...
It is primarily for health workers?
Yes.
And for those who have relatives who have been exposed?
Yes, okay. And for the exposed person, because then the person, when they are coughing, they must protect themselves so that they don't spread it. Okay. And then let's practice very good cough etiquette. Right. Sneezing in public places, we should make sure that our nose is covered. Right. Let's also, the distancing, we should start practicing it now. Okay. And currently, I think this virus has been very kind to us. Right. It's giving us space to plan. So let's start changing our habits so that we can, because change of habit is difficult. Right. If we have 100 people and we suddenly want to change, it will be difficult.
Yes, so Dr. Boydu, finally, what do you have to say in addition to that? What should we do?
Yes, one thing I want to tell the public and an assurance I'm giving them is that Ghana has the capacity in human resource to manage COVID-19. What we need to do now is that we have started refresher courses. We are getting it down to the bottom line, to the chip zone, that every healthcare person will now be more sensitized to be looking out for the COVID-19. We have places to keep those who happen to be infected, and we have our management protocols to take care of them. What we need now is that we need the support of the country. We need the community to support us, give us the backing in terms of logistics, in terms of needs that will help these people. Insurances to keep the front lines actively working. And I know we can overcome it.
Thank you very much. Dr. Lawrence Ofori-Boadu is emergency medicine specialist and Deputy Director, Clinical Services Department at the Ghana Health Service. Here also for this issue that we have discussed have been Dr. Titus Bayo, Deputy General Secretary and Member Infectious Diseases Committee of the Ghana Medical Association. Also Dr. Franklin Esiedu Bequim, Deputy Director, Public Health and Head, Disease Surveillance at the Ghana Health Service. And of course, Dr. Abena Asmani Enchi, Health Economist, Policy Analyst and Analysis and Healthcare Access Expert. And she is the author of these two books, Purposeful Chaos. Purposeful Chaos. Move from it. Okay. Move from it can be done to it has been done. Move from it can be done to it has been done. And this other one, the side we choose to see. The side we choose to see. Thank you all so very much for making time to educate Ghanaians on NewsFile on COVID-19. Thank you very much.
Thank you.